The frontline therapy for patients with myelofibrosis typically are medications that would tackle the anemia and then symptomatic splenomegaly or general systemic symptoms. And most of the time, we would use JAK inhibitors for spleen and symptoms. And for anemia, we may use erythropoietic stimulating agents or danazol or prednisone. Sometimes we combine these things together, but main problem is that they may not work forever. And then the question is, what do we do? If patients on a JAK inhibitor, for example, don't do well, we can add another agent. So navtemadlin is one of these new medications, an MDM2 inhibitor, which combined with ruxolitinib, for example, in people who are not doing well, so-called suboptimal responders to the frontline ruxolitinib therapy, have that agent added, and it may improve the spleen and symptoms. It may also be active in a second-line setting after JAK inhibitor. We have patients then that still suffer from a spleen, symptoms, and anemia, and they don't have too many options. In that setting, second-line setting, navtemadlin was shown in a phase II study to be active in controlling the spleen and symptoms. In fact, at the moment, there is underway a global phase III study called BOREAS study that is examining the activity of navtemadlin, an MDM2 inhibitor, versus best available therapy, excluding a JAK inhibitor, as a possible new therapy for patients in this problematic situation, a second-line setting after initial JAK inhibitor. So people are randomized between the navtemadlin and the best available therapy to see whether the navtemadlin will be better in controlling the spleen and symptoms. That's a phase III randomized study for possible approval of navtemadlin in this setting.